Hello there. So now let's move on to the next scenario in gastroenterology. So here we have a 54-year-old woman who is a known case of pernicious anemia refusing to take hydroxycobalamin intramuscularly as she's needle shy. She's asking for oral medication. Now, what is the single best reason that describes why oral medications will not be effective? So, pernicious anemia is caused by an autoimmune atrophic gastritis, which leads to chlorhydria and lack of Casel's intrinsic factor, that is gastric intrinsic factor secretion. Injections are required. So, if the cause of vitamin B12 deficiency is not due to pernicious anemia, uh, and that is it is dietary, then oral B12 can be given after initial acute course. So here we have to understand that pernicious anemia is caused by an autoimmune atrophic gastritis, which is leading to a chlorhydria, and also it causes lack of Casel's intrinsic factor or gastric intrinsic factor secretion, which is used for vitamin B12 absorption. Therefore, there is deficiency of vitamin B12 because of this, and injections are required. Injections of hydroxycobalamin are required because even if we are taking orally, it is not getting absorbed because of the lack of intrinsic factor. Therefore, this hydroxycobalamin has to be given intramuscularly, so it has to be given through injections. But if the cause of vitamin B12 deficiency is not due to pernicious anemia, or it is basically due to dietary factors, that is like vegan diet, etc., in that case we can give oral vitamin B12 or oral hydroxycobalamin. So that is to be remembered. Now let's move on to the next question. Now, a 44-year-old man complaining of intermittent dysphagia for the past 5 weeks. He also has nocturnal cough, and he has dropped his weight from 80 kgs to 70 kgs during this period of 5 weeks. Occasionally, he suffers from heartburn when lying flat. He does not smoke, no significant medical history. What is the single most appropriate investigation in this case? Now, we know that it is a kind of a controversial question, and the top two choices would be endoscopy and video fluoroscopy or barium swallow. Video fluoroscopy or barium swallow or endoscopy. So the differentials which need to be considered here are diffuse esophageal spasm, eclasia, scleroderma, esophageal ring, esophageal cancer, and esophageal web. The description in this question best fits a case of eclasia. Patient is having intermittent dysphagia, and so this seems to be a case of eclasia as the patient is young. Cancer is unlikely in such patient, so understandably many candidates would pick barium swallow rather than endoscopy because cancer is unlikely. But although barium swallow is less invasive, it can be used to diagnose conditions like diffuse esophageal spasm or eclasia. However, it is an incorrect option. Patients with dysphagia, despite their age, they should undergo endoscopy with esophageal biopsy so as to rule out and treat mucosal and structural disorders first. So it is not just cancer which we are ruling out here. Even those patients who are just having dysphagia despite their age, irrelevant of their age, irrespective of their age, they should also undergo endoscopy so as to rule out any mucosal or structural disorders. So they should carry undergo endoscopy and esophageal biopsies. Now, barium swallow is considered where endoscopy is not possible, or if endoscopy is normal but a structural abnormality is still suspected. So that is to be remembered that barium swallow is considered where endoscopy is either not possible or it is normal but structural abnormality is still suspected. So although endoscopy will not diagnose achalasia, it is one that needs to be performed first so as to exclude malignancy, so as to exclude any mucosal and structural disorders. So it is to be carried out first according to NICE guidelines. These things have changed, although other investigations or the most accurate investigation or gold standard would be manometry, and in conclusion, this thing has to be remembered that in dysphagia, initial investigation is always endoscopy with exception of pharyngeal pouch. And in dysphagia, if there is diffuse esophageal spasm or achalasia, then if they are asking most appropriate investigation, not most initial investigation, they are asking most appropriate investigation. If they are asking most appropriate initial investigation, it will still be endoscopy. If they are just asking about most appropriate investigation, then it would be barium swallow or manometry, esophageal manometry. Now let's move further. Now we have a 28-year-old man having intermittent diarrhea, fatigue, weight loss over the past 6 months. He has excluded gluten from his diet in the last 2 months. His symptoms have resolved. He wants to be tested to confirm the diagnosis of celiac disease. Now, what is the single most appropriate next step in action? Now we know that for carrying out to confirm the diagnosis of celiac disease, we have to carry out endoscopy. Duodenal, jejunal endoscopies and biopsies. For that, we have to make sure that the patient is not on gluten-free diet. So we have to reintroduce gluten prior to testing. If the patient is already taking a gluten-free diet, then advice should be given so as to reintroduce or restart gluten for at least 6 weeks prior to performing biopsies or serological tests. Serology tests and intestinal biopsies may come back false negative if the patient is taking a gluten-free diet. They may show false results. For at least 6 weeks before testing. So the patient should be on gluten. Patient should be taking gluten diet that time before carrying out these biopsies and serology tests. And if they are already on gluten-free diet, gluten should be reintroduced for at least 6 weeks before testing. For the test to be accurate, this should be done. So this should be remembered. Now let's move further. Now we have a 28-year-old type 1 diabetic having intermittent diarrhea, abdominal bloating over the last 6 months. He also complains of feeling tired all the time. Blood tests are showing hemoglobin 135, ferritin 30, thyroid stimulating hormone is 2.5, immunoglobulin IgA tissue transglutaminase is positive. What is the single most appropriate next step in action? So there is an association between type 1 diabetes and celiac disease. The gold standard to confirm the diagnosis of celiac disease or gold standard to diagnose celiac disease is duodenal or jejunal biopsies. These biopsies are still required even though the serological tests like tissue transglutaminase antibody TTG, IG antibodies are positive for celiac disease. Even then, we have to conduct these biopsies to confirm the diagnosis. In the past, small bowel biopsies for the diagnosis of celiac disease were taken from jejunum, but nowadays, most gastroenterologists take endoscopic biopsies from the distal duodenum. So, simply, we have to understand that there is an association between type 1 diabetes mellitus and celiac disease. Gold standard for diagnosis of celiac disease is duodenal or jejunal biopsy, and these biopsies are required even when the serological tests or antibody tests like tissue transglutaminase antibody IgA, these are positive. Even then, we have to perform duodenal or jejunal biopsies. So this should be conducted here in this case. It would be the single most appropriate next step in action. Now let's move ahead. Now we have a 45-year-old man complaining of epigastric pain and passage of loose stool for the past 3 months. A full blood count indicating iron deficiency anemia, prompting the gastroenterologist to perform an endoscopy, and the endoscopy reveals multiple ulcers involving the lower esophagus, stomach, duodenum, proximal jejunum. Which of the following is a single best initial investigation to determine the cause of the ulcers? So, the endoscopic report of multiple ulcers in the esophagus, stomach, duodenum, and jejunum should raise the suspicion for Zollinger-Ellison syndrome. Furthermore, the complaint of passing loose stools increases the likelihood of this condition. Zollinger-Ellison syndrome. So, whenever there are multiple ulcers, some are usually in unusual locations, such as beyond the duodenum, and there is diarrhea along with that. We always should think of Zollinger-Ellison syndrome. So, multiple ulcers, some even in unusual locations beyond duodenum. Usually, they can be found in esophagus and stomach, duodenum, even jejunum, some even beyond duodenum. Along with that, along with these multiple ulcers, diarrhea is also present. So, always in this picture, we always have to think of Zollinger-Ellison syndrome. Now, gastrinomas are neuroendocrine tumors of duodenum, pancreas, abdominal lymph nodes which secrete gastrin. And this gastrin stimulates an increase in the production of acid in the stomach, which leads to formation of ulcers. So, gastrinomas, these are neuroendocrine tumors of the duodenum, pancreas, and abdominal lymph nodes, which secrete gastrin, and this gastrin further stimulates uh, and increases the production of acid in the stomach, which leads to formation of ulcers. Therefore, the investigation to confirm Zollinger-Ellison syndrome is the measurement of serum gastrin levels. A fasting serum gastrin level of more than 1000 picogram per ml with a gastric juice pH of less than 2 suggests Zollinger-Ellison syndrome. So if fasting gastrin level is more than 1000 and gastric juice pH is less than 2, it clearly suggests Zollinger-Ellison syndrome. Full blood count may indicate iron deficiency anemia. While this is a finding of peptic ulcer disease, it does not indicate the likely cause of the ulcers. C3 C13 urea breath test is an excellent investigation in diagnosing peptic ulcer disease secondary to H. pylori. So here we are referring to Zollinger-Ellison syndrome, and the best initial investigation to determine the cause of the ulcers would be serum gastrin levels. The endoscopic report of multiple ulcers here in esophagus, stomach, duodenum, jejunum, they raise the suspicion of Zollinger-Ellison syndrome. Furthermore, there are complaints of passing loose stools, which further increases the likelihood. So always, if there are multiple ulcers in esophagus, stomach, duodenum, jejunum, uh, and unusual sites, along with that, there is history of diarrhea, loose stools. We always have to think of Zollinger-Ellison syndrome. Now, gastrinomas are neuroendocrine tumors of duodenum, pancreas, and abdominal lymph nodes which secrete gastrin. Duodenum, pancreas, and abdominal lymph nodes. And these gastrinomas secrete gastrin. This gastrin further stimulates production of gastric acid and causes excessive secretion of gastric acid in the stomach, leading to peptic ulcer disease, leading to formation of ulcers. Therefore, the investigation to confirm Zollinger-Ellison syndrome is the measurement of serum gastrin levels. A fasting serum gastrin level of more than 1000 plus gastric juice pH less than 2 indicates Zollinger-Ellison syndrome. Fasting serum gastrin level more than 1000 plus gastric juice pH less than 2, it indicates Zollinger-Ellison syndrome. Full blood count may indicate iron deficiency anemia. This is a finding of peptic ulcer disease, but it is not pointing towards the cause of the ulcers. C13 urea breath test is an excellent investigation to diagnose peptic ulcer disease secondary to H. pylori. So this was about Zollinger-Ellison syndrome. Let's see if we have a chart on this. We do have gastrinomas leading to excessive gastrin levels, leading to multiple and refractory peptic ulcers in the distal duodenum and proximal jejunum. Presentation: epigastric pain, GI bleeding due to erosion, chronic diarrhea associated with MEN1. Investigation: fasting serum gastrin levels, then endoscopy to look for ulcer, CT scan to locate the tumor, that is gastrinoma, neuroendocrine tumor of duodenum, pancreas, and abdominal lymph nodes. Treatment is surgical resection of the tumor and proton pump inhibitor. So in Zollinger-Ellison syndrome, basically it is caused due to gastrinoma, which is a neuroendocrine tumor, which leads to excessive secretion of gastrin, which further stimulates production of gastric acid in the stomach, excessive secretion of gastric acid in the stomach leading to peptic ulcer disease. Investigation: fasting serum gastrin, endoscopy to look for ulcer, CT scan to locate tumor. And treatment is surgical resection of the tumor and proton pump inhibitors. And presentation would be epigastric pain, GI bleeding due to erosion, then chronic diarrhea and association with MEN1. Let's move ahead now. Now we have here a 56-year-old man who had a history of intermittent epigastric pain at night for the past 3 months. He has lost 5 kgs in weight over the past 3 months unintentionally. He's not on any regular medications, drinks around 20 units of alcohol a week for the past 5 years. No palpable abdominal mass on examination. Abdomen is soft and non tender. What is the single most appropriate action in this case? So, this is a question which tests our knowledge on urgent interventions. We should remember that an urgent endoscopy or urgent upper GI endoscopy or esophagogastroduodenoscopy should be performed in the patients with 55 years of age, having weight loss, and plus any of the following, that is dyspepsia, gastric reflux, and abdominal pain. So, this patient, 55 years of age or more, with dyspepsia and weight loss, we have to carry out urgent esophagogastroduodenoscopy to look for esophageal and gastric cancers. Heavy consumption of alcohol is associated with increased risk of esophageal cancer and gastric cancers. Now, another option here is fecal elastase, which is used to investigate chronic pancreatitis. Chronic pancreatitis can also present with weight loss and intermittent epigastric pain, and alcohol is also a risk factor for chronic pancreatitis. However, the importance should always go towards investigating cancer first, which is the reason that an urgent esophagogastroduodenoscopy is a better option as compared to fecal elastase here. So we have to have a certain knowledge about urgent interventions as well. An urgent upper GI endoscopy or esophagogastroduodenoscopy should be performed in patients who are 55 years of age and older with weight loss and any of the following, that is dyspepsia, gastric reflux, or upper abdominal pain, or the patient is having dysphagia. Heavy consumption of alcohol here is associated with increased risk of esophageal cancer and gastric cancer. So we are carrying out this endoscopy to look for esophageal and gastric cancer. And heavy consumption of alcohol is a risk factor. Fecal elastase is used to investigate chronic pancreatitis. This chronic pancreatitis can also present with similar picture with weight loss, intermittent epigastric pain. Alcohol is also a risk factor there. However, the importance first, more importance is given towards investigating cancer first, which is the reason urgent esophagogastroduodenoscopy is a better option to go with as compared to fecal elastase. So, dysphagia or 55 years and over with weight loss, any of the following, that is dyspepsia, reflux, upper abdominal pain, or the patient is having refractory or recurrent symptoms of dyspepsia despite optimal management, usually proton pump inhibitors for 4 weeks, or treatment with a second line H. pylori eradication regimen has been unsuccessful. We have to ensure the person stops any acid suppression therapy for at least 2 weeks before the endoscopy date. So this is about urgent interventions. Let's move ahead now. A 64-year-old man presenting to the clinic with lethargy and dull pain in the right hypochondrium that has been worsening over the past for a few months. He has significant weight loss over the last several weeks. On examination, he is noted to have a slight yellowish tinge of his skin and whites of his eyes. Abdominal palpation reveals a tender right upper quadrant with a firm enlarged liver. Further investigations were performed over the next few weeks. The histology of his liver biopsy returns with the report showing evidence of adenocarcinoma and immunostaining of thyroid transcription factor, that is TTF1, indicating a primary pulmonary tumor. What is the single most likely route of metastasis in this patient? So, hematogenous spread to the liver from lungs is the most common route of metastasis. And TTF1, that is thyroid transcription factor, is a protein seen by immunostaining which is used as a clinical marker of lung adenocarcinoma. So metastasis can occur to liver in males from lungs or from stomach or from colon, whereas in female metastasis to liver can occur from breast, from stomach, from colon, and from uterus. And gastric carcinoma is associated with blood group A. This should also be remembered. And the most common primary sites for hepatic metastasis are colorectal, stomach, pancreas, breast, lung, and eye. In children, more commonly are neuroblastoma, Wilms tumor, and leukemia. So these are the things which we should remember about metastasis or spread of the tumor to liver. So spread of tumor from lungs to liver or metastasis from lungs to the liver is most commonly through hematogenous route. So hematogenous spread to the liver from lungs is the most common route of metastasis. Hematogenous route is the most common route of metastasis from lungs to the liver. And thyroid transcription factor, that is TTF1. This thyroid transcription factor TTF1, which is a protein seen by immunostaining, is used as a clinical marker of lung adenocarcinoma. So thyroid transcription factor, it is used for lung adenocarcinoma. Other things to be remembered are the common sites of hematogenous metastasis include brain, bones, liver, adrenal glands, bone marrow, and thyroid transcription factor 1 indicates lung adenocarcinoma. Lungs to liver is hematogenous spread, and It is like from lungs spreads to heart, then it spreads to aorta, then it spreads to celiac trunk, then it spreads to common hepatic artery, then liver. From lungs to heart to aorta to celiac trunk to common hepatic artery, then to liver. Now, in male, metastasis to liver is from stomach, lungs, and colon. In female, it is from stomach, colon, breast. It is from stomach, breast, colon, and uterus. And the most common primary sites for hepatic metastasis are stomach, pancreas, colorectal, colon, that is colon, rectum, stomach, pancreas, breast, lungs, and eyes. In children, most common primaries are neuroblastoma, Wills tumor, and leukemia. So now let's move ahead. A 52-year-old man presenting to emergency department with complaints of worsening epigastric and back pain. The pain is episodic. There are times that he is pain-free. He has presented 3 times to his GP in the past 6 months with generalized abdominal pain. He has complaints of having loose, pale, offensive stools. He has lost weight over the past few months, which he attributes due to the fear of eating, as the pains often worsen after eating. He drinks 25 units of alcohol in a week. On examination, he has epigastric tenderness. An X-ray of the abdomen was performed, which showed diffuse calcifications in the abdomen. Now, what is the single most likely diagnosis? So, an X-ray of the abdomen was performed, which shows diffuse calcification in the abdomen, and single most likely diagnosis is being asked here. So this is a case of chronic pancreatitis, and we have to study a little more about it. Chronic pancreatitis often presents with abdominal pain, and classically this pain is located at the epigastrium radiating to the back. Pain is worse after eating and leading to a dislike of eating, which is consequently leading to weight loss. Pain-free intervals are common in chronic pancreatitis. Now, second most predominant feature here is malabsorption, which is represented here by steatorrhea, and malabsorption again contributes to weight loss. Alcohol is one of the significant risk factors for chronic pancreatitis, but it is not a good hint to pick chronic pancreatitis as the answer based on alcohol history, as alcohol also contributes to acute pancreatitis, gastroesophageal reflux, esophagitis, and indirectly to pancreatic cancer as well. One might consider carcinoma of the head of pancreas as the answer because of the similar symptoms like weight loss, epigastric pain, history of alcohol, but in reality it is difficult to differentiate the two, hence the importance of imaging modalities such as ultrasound and CT scan. In chronic pancreatitis, plain abdominal films of the pancreas can show diffuse calcification, which indicates significant damage to the pancreas. X-rays of the abdomen are not one of the main imaging modalities of the pancreas. It is usually done for other reasons, so as to exclude out bowel perforation, etc. Again, to stress that ultrasound and CT scans would be a better imaging modalities for pancreatic diseases. So let's study a little more about chronic pancreatitis. Now, the causes of chronic pancreatitis, these are alcohol, seen in majority of the cases, then smoking, and autoimmune. Clinical features, classically it presents with epigastric pain radiating to the back. Pain is relieved when sitting forward. Pain is the most common presentation. Pain is episodic with short periods of severe pain, and eating may further exacerbate the pain. It may increase the pain. Second feature is steatorrhea. Steatorrhea occurs due to malabsorption of fats due to the lack of pancreatic lipase secretion, which could subsequently cause weight loss. So, steatorrhea is there, so occasionally the questions may include words like offensive stools, which are difficult to flush. In other words, they represent the term steatorrhea. Another feature of chronic pancreatitis is diabetes, and another feature, last feature of chronic pancreatitis would be jaundice. Jaundice is a later presentation which occurs due to obstruction of the common bile duct when the head of pancreas becomes fibrosed. So jaundice is a late feature of chronic pancreatitis, and it occurs due to obstruction of the common bile duct due to involvement of the head of the pancreas, which becomes fibrosed. So we need to remember that patients with chronic pancreatitis seek medical attention mainly because of symptoms of abdominal pain, maldigestion, and weight loss. Now, investigation here are fecal elastase, transabdominal ultrasound scans, and contrast lens spiral CT scans, and serum amylase and lipase. So, investigations in chronic pancreatitis are fecal elastase. Low levels are diagnostic for exocrine pancreatic insufficiency. It is the most commonly used test for exocrine function. Then, apart from fecal elastase, ultrasound scan, transabdominal ultrasound scan, used for initial assessment to look for biliary obstruction. Then, contrast enhanced CT scan, which is the gold standard for imaging technique for pancreatic disease. Contrast enhanced CT scan. Then, serum amylase and lipase. Serum amylase and lipase here may be elevated. However, in contrast to acute pancreatitis, levels are not strikingly elevated, and in many cases, they are even normal. So, they are not included in investigations here. Sorry. So, serum amylase and lipase are much more elevated in acute pancreatitis, actually. In chronic pancreatitis, they may either be normal or they may be slightly raised. Ultrasound scan of abdomen are useful in the detection of gallstones if gallstones are suspected cause of pancreatitis. If exocrine pancreatic insufficiency is confirmed, then pancreatic imaging such as CT scan would be more appropriate than an ultrasound scan. So, a CT scan of the pancreas would show atrophy, calcification, or duct dilatation. So, fecal elastase, transabdominal ultrasound scan, contrast enhanced CT scan. Contrast enhanced CT scan is the gold standard imaging technique for pancreatic disease. Amylase, lipase, they are not much elevated, or sometimes they are even normal in chronic pancreatitis, unlike acute, where they are strikingly elevated. Now, management. For pain, we will carry out analgesia. For shatoria or malabsorption, we have to give pancreatic enzyme supplements and fat soluble vitamins. Then, for diabetes, we will give oral hypoglycemic drugs and insulin. Now, let's go through the chart. Here we can see typically affects alcoholic or elderly patients, and presentation is long-standing episodic epigastric pain radiating to the back. Staturia leading to malabsorption leading to weight loss and diabetes mellitus. Here we can see pancreatic calcification as well. Now investigation are fecal elastase, which is low in exocrine pancreatic insufficiency. It's a good test to pick in the exam if asked for investigation for a patient with symptoms of chronic pancreatitis. So fecal elastase, second ultrasound abdomen, third CT scan abdomen. Ultrasound abdomen for suspected biliary disease, CT scan abdomen, contrast and CT scan abdomen for pancreatic calcification, atrophy, duct dilatation, etc. Amylase lipase not as high as seen in acute pancreatitis, majority are normal, so don't pick this in the exam when thinking of chronic pancreatitis. Treatment is by analgesics, pancreatic enzyme supplements, and fat soluble vitamins. And for diabetes, we can give oral hypoglycemic drugs and insulin. So, for chronic pancreatitis, once again, causes are alcohol, seen in majority of the cases, smoking and autoimmune. Clinical features: epigastric pain classically presents with epigastric pain radiating to the back. Pain is relieved sitting forward. Most common presentation is episodic with short periods of severe pain. Eating may further aggravate or exacerbate, increase the pain. Second is steatoria. Steatoria is due to malabsorption of fats due to the lack of pancreatic lipase secretion, which can cause subsequent weight loss. So we may find terms like offensive stools, difficult to flush, etc. Then diabetes and jaundice, which is a later presentation, which is occurring in chronic pancreatitis due to obstruction of common bile duct due to fibrosis of the head of the pancreas. When head of the pancreas becomes fibrous. Investigations are fecal elastase, then transabdominal ultrasound, and contrast and CT scan. Management for pain, analgesia, steatoria, and malabsorption, we will give pancreatic enzyme supplements, fat soluble vitamins. For diabetes, oral hypoglycemic drugs and insulin. And let's go through the chart once. Typically affecting alcoholic or elderly. Presentation: long standing episodic epigastric pain radiating to the back. Steatoria leading to malabsorption. Steatoria leading to malabsorption, leading to weight loss. And diabetes mellitus. And jaundice late presentation. And we see here pancreatic calcifications. Now investigation fecal elastase, which is low in exocrine pancreatic insufficiency. Then ultrasound abdomen and CT scan abdomen with contrast can be useful for seeing calcification, atrophy, or dilatation. Amylase lipase not as useful as in acute pancreatitis because these are either normal or slightly raised, not as elevated like in acute. Treatment is by analgesics, pancreatic enzyme supplement, and fat soluble vitamins. Now let's study a little about postprandial pain here. So for postprandial pain, we have to remember certain things. Postprandial pain, first gastroesophageal reflux disease causing burning sensation and it is radiating upwards towards the throat. Second cause is pancreatitis, acute and chronic. Food triggers release of enzymes of the pancreas, which often worsens the pain. So there is epigastric pain in acute pancreatitis. There is nausea, vomiting, and fever. In chronic pancreatitis, there is weight loss, smelly and oily stools. Peptic ulcer disease. In peptic ulcer disease, pain occurs 2 to 5 hours after a meal or on an empty stomach. Gallstones. In gallstones, pain especially becomes worse after eating a meal high in fat. It is associated with nausea and vomiting. Last is irritable bowel syndrome. The pain may be worsened soon after eating, relieved at times worsen after a bowel movement. There is abdominal pain, bloating, change of bowel habits for a period of at least 6 months. Symptoms can be precipitated by stress. So, postprandial pain, we can have different causes like gastroesophageal reflux disease or acute and chronic pancreatitis, peptic ulcer disease, gallstones, and irritable bowel syndrome. Gastroesophageal reflux, there will be burning sensation radiating to the throat. Pancreatitis, food will trigger release of enzyme of the pancreas, worsening the situation, worsening the pain, epigastric pain. In acute pancreatitis, nausea, vomiting, fever. Chronic pancreatitis, weight loss, smelly, oily stools. Peptic ulcer, pain will occur 2 to 5 hours after a meal or on empty stomach. Gallstones, pain is worse mainly after taking a meal which is high in fat, associated with nausea and vomiting. Irritable bowel syndrome, pain is worsened soon after eating. It is sometimes relieved or sometimes worsen after a bowel movement. There is abdominal pain, bloating, change of bowel habits for a period of at least 6 months. And symptoms in irritable bowel syndrome can be precipitated by stress. Now, another thing here to see is pancreatic cancer versus chronic pancreatitis. So, why it is difficult to differentiate the two? They can share very similar symptoms like loss of appetite, anorexia, weight loss, diabetes. Both can produce abdominal and back pain, or both can be painless. Similar risk factors like alcohol and smoking. Now, both conditions occur concurrently as well. Recurrent acute pancreatitis may lead to chronic pancreatitis. Chronic pancreatitis may lead to pancreatic cancer. Pancreatic cancer may further cause acute pancreatitis. What should we look out for? In chronic pancreatitis, now we have to remember certain important points here in chronic pancreatitis. First is alcohol. Second, cystic fibrosis if the patient is young. Third, history of acute pancreatitis. Then fourth, recurrent attacks of pain. There are also pain-free intervals in chronic pancreatitis. And fifth, calcification. Pancreatic cancer. In pancreatic cancer, we have to remember certain points like smoking, then jaundice, third, hepatomegaly, fourth, pain which is insidious in onset, fifth, severe back pain, and sixth, CA19-9. So in pancreatic cancer, we have to remember smoking, hepatomegaly, jaundice, pain insidious in onset, severe back pain, and CA19-9. These are the things. What about pain now? Pain is the most common symptom with chronic pancreatitis. It is not uncommon with pancreatic cancer. At diagnosis, we will see epigastric pain in 70%, back pain in 50%. Both can present with epigastric pain radiating to the back. Both can have intermittent or continuous pain, or both can be painless. So main is these points, important points, like in chronic pancreatitis, alcohol, cystic fibrosis in young patient, history of acute pancreatitis, recurrent attacks of pain and pain-free intervals, and calcification. In pancreatic cancer, smoking, hepatomegaly, jaundice, pain which is insidious in onset, severe back pain, and CA19-9. Now let's take a small break and I'll be back.